So welcome everyone. Good afternoon. Thanks for being here with us. As you heard this afternoon, we're going to talk a little bit about best practices for patients as we navigate our PKD journeys. And you're going to hear perspectives from both the patient view, which is mine. I am a PKD patient, had a living donor transplant 3.5 years ago. And Dr. Perrone, who is well known to many of you who've been involved with the PKD Foundation, will share the physician perspective on best practices as we interact with each other, patients and healthcare providers, that is. We're going to look at the patient and what you should be asking, what you should know, and how comfortable you should be along the way, and what you should expect in return from your providers. So we're going to do this a little bit chronologically, talking through stages of PKD. As with any chronic disease, you're going to have different experiences depending on where you are in the life cycle. So we'll start at the beginning, of course, which is when the patient is new to PKD. And our goal for this segment would be to talk about who is your nephrologist. Have you done the necessary work to figure out if you have the right practitioner? How comfortable are you together? And that will be a foundation on which is based your entire treatment along the way. So I want everyone to know and to really take to heart the fact that we each deserve to have the very best care that we can. And that takes work on our part as well as on the part of our caregivers. So remember that we are our own best advocates in this process, and we have the ability to bring along with us others who may be good advocates and helpmates to us, and feel comfortable throughout your entire PKD journey to do so, and to bring these people with you and to feel empowered to ask questions. And you'll hear that over and over, but it has served me well, and I think it would everyone. So when you meet your new practitioner, the questions are often around how much does this practitioner know about PKD? What is her or his experience clinically? And you should feel comfortable asking them to tell you all of those things. You're going to want to speak with them at length about how many patients they treat, and what their approach is, and how often they would want to see you, et cetera, et cetera. Do not be afraid, because in this process, what you're doing is developing a rapport. And if you find that you're uncomfortable asking questions, then maybe you don't have the rapport that you would like to have with this particular practitioner. You will talk about, hopefully, clinical trial opportunities, even in the very earliest stages of PKD, because that is a way for you as an individual to get some particular information and perhaps additional care, certainly more eyes on you along the way, but also it benefits our next generations and the whole PKD community. So last thing I want to say about this is that this is a process, and everyone should expect perhaps to have to do this more than once to find the right fit. But there is no substitute for finding the practitioner that best meets your needs. And now we're going to ask Dr. Perrone to present from his point of view. When a patient is new to PKD, what should you expect your doctor to be looking for?
Thank you, Judy. So your PKD physician should approach your care in a very comprehensive fashion. So the physician needs to establish what are you, the patient's manifestations of autosomal dominant PKD. What is your present status in terms of kidney function and your progression along the pathway? What are potential treatments and interventions for ADPKD, for general and cardiovascular health, for psychosocial function and well-being, and also regarding counseling, family planning, and kids. So I'm going to go through each of these in more detail. So regarding your diagnosis, How did you come to get diagnosed? Did you present with symptoms leading to a trip to the emergency room for pain in the belly or blood in the urine? Did you have imaging that was designed to detect PKD versus, for example, if you were in an auto accident and you were in the emergency room, and almost everyone gets a CAT scan in the emergency room, and whether you were diagnosed through genetic testing at an earlier stage of your course. So it's very important that the kidney doctor does what I would call a complete staging of the kidney disease. And this includes all of the bullet points shown on this slide. So we know, for example, that kidney size at a given age is a very important factor toward predicting progression. And we use the Mayo Clinic classification that looks at kidney volume as a function of age. And if you have small kidneys at a young age, that's good. If you have large kidneys at a young age, that's not good. That indicates you're at risk for progression. As kidneys enlarge, which is very common in polycystic kidney disease, the abdomen becomes enlarged. And this can be very distressing for people as regards their perception of their body image. Other issues are whether you've had kidney or flank pain, whether you've had bleeding, kidney infections, cyst infections, or stones, and what may have brought on the kidney pain or the bleeding. And the doctor should encourage you to not do that activity that results in bleeding. The doctor should also discuss with you how often you pass urine, whether you pass urine at night, and whether you pass urine more frequently, because we know that the polycystic kidneys don't concentrate the urine or hold on to urine as well as normal kidneys. Hypertension or high blood pressure is one of the most common aspects of polycystic kidney disease, and hypertension should certainly be detected and treated. And I've certainly encouraged many of my patients to get a home blood pressure monitor, to have it checked in the physician's office, and to do additional readings of blood pressure other than those when you see a physician. Of course, your kidney function should be measured. We measure this using the level of creatinine in the blood, and we use an estimate of your glomerular filtration rate, or GFR, to figure out where you are. Normal GFR is about 100, and people typically start dialysis or get a kidney transplant when they're below 15. The other thing to look at is the presence or absence of protein in the urine, known as proteinuria. And more protein is bad in the urine, and less protein is good. Judy, I'm handing the podium back to you.
Which is a good segue, because now we understand really that that first visit or series of visits are going to be very productive in terms of information both for you and your practitioner. So as your PKD progresses, we'll call it early to mid stage. Now, of course, that is a long stretch, can be very different for different patients, but for purposes of how you should expect your visits and your relationship with your practitioner to go, early to mid stage would be that time when things are relatively stable. And the goal for the patient during this time is really to understand any changes that you may be experiencing. And if you are experiencing changes, understanding what's causing them and what, if any, changes can you make to be proactive in your lifestyle, in your diet, etc., to track very closely how you're doing. And of course, the goal is always to do everything we can to slow the progression of our PKD. So Dr. Perrone just mentioned that he likes patients to have a home blood pressure monitor, and having been one of his patients, I've always had one. And so one of the things we're going to do as patients is take responsibility for bringing our information to our visits. So always show up with your blood pressure readings, with the current medications that you're taking, or list of the medications, I should say. Show up with your understanding of your labs, whatever they either were your last time around, or if you've already had them done for this visit. Sure, you will have questions, and it's important to ask them and have them answered. So again, we're going to be looking at what's changed. How are you doing? What have you noticed? Have you had any other visits with any other practitioners? So I want to just point out here that, let's say I go to see a cardiologist for some reason because my PCP sends me there. Well, let's not assume that our nephrologist doesn't care about that visit because it has nothing to do with the kidneys. As we know, PKD is a systemic disease, and our nephrologists, in fact, are very interested, not only because the condition may somehow impact or be impacted by your PKD, but also because perhaps your other doctors prescribe some kind of medication. And it's important for all physicians to be aware of all the medications you're taking so that we can avoid any unwanted interactions. So again, I'm encouraging everyone to come with questions, come with your status as you see it, and find out from your practitioner so you both understand, where are you at this point in time? Are you stable? Are you progressing? Have certain things improved? Your kidney function will not likely improve over time, but it certainly will fluctuate from blood test to blood test, so don't be surprised by that. You will hear us talk often about clinical trial opportunities. Discuss it again with your practitioner. I cannot overstate the importance of us as PKD patients being willing and able and excited to participate in this research, because if we do not, we will never have treatments or a cure for PKD. We're the only ones who can do it. And then finally, at the end of every visit, you're going to talk about next steps, and next steps will always include, when should I come back? Is 6 months still good? Should it be more often? And that decision will be made between you and your practitioner.
Thank you, Judy. So the treatments that are available to you depend on the stage of your progression. I want to mention that supportive care and general health measures are very, very important. Everyone with kidney disease is at increased risk for heart disease. And anything you do to lower your risk of heart disease is also good for your kidneys. So these are very important measures. If a doctor says to you, there's nothing I can do, come back when you need dialysis, you need another doctor. So the things that we focus on, we manage high blood pressure. We generally advise a low or modest intake of caffeine. There isn't really strong proof that caffeine is bad for your kidneys, but there is some experimental evidence that would suggest so. So go easy on caffeine. Maintain a high water intake of approximately 2 to 3 liters or 2 to 3 quarts per day. And you should discuss that with your doctor prior to increasing your water intake. Having a large water intake helps to reduce the risk of kidney stones. It may block the secretion of vasopressin, which is a hormone associated with kidney progression. It's not a magic therapy. A recent clinical trial in Australia as regards water intake did not show protection, but most people weren't able to drink enough water. Consider other measures to reduce progression, including mild protein restriction of 0.8 grams per kilogram body weight and salt restriction. And this should be done with a kidney-wise dietitian. Your doctor should assess your kidney volume at least once and assess it using the Mayo imaging classification. And again, this is a roadmap as to your risk of progression and may also provide your eligibility to take tolvaptan, which is the only drug that's been approved for the treatment and slowing of progression in PKD. And of course, this is a discussion that you have with your doctor to discuss the risk and benefit of such an intervention. And in a more advanced stage, you need to plan for kidney replacement therapy including dialysis and transplant. So many patients I've seen have the thought that just maybe it's not going to be me. Maybe I'm not going to progress. And we know in the early stages of progression, the serum creatinine levels may be pretty stable. They may be normal. But knowing what your kidney size is and knowing what your family history is gives the doctor a clue as to what the future holds. Another thing to consider is those that are thinking about needing a kidney transplant or approaching that stage of their disease. When you're at family reunions or weddings or other family events, you can chat with your other family members to see who may be willing to donate. And because of the 50% likelihood of PKD in the family, there are fewer living kidney donors available for such. So these are conversations that people can have on a voluntary basis. The other important consideration are the extrarenal manifestations, that is, things other than the kidneys. This would include screening for brain aneurysms. Aneurysms are weakenings of the blood vessels in the brain, and they can rupture, which is a very, very bad thing. And people who are at risk for that need to be screened. I would avoid estrogen, either oral contraceptives or hormone replacement therapy in women due to the likely worsening of liver cyst disease. And as I mentioned, cardiovascular risk reduction due to increased risk of cardiovascular complications and any form of chronic kidney disease. So we want to get your low density lipoprotein cholesterol, your LDL cholesterol, that's the bad cholesterol, below 100. You want to eat a healthy diet. You want to maintain an optimal body weight. And there's new evidence now that weight loss to an optimal body weight is associated with reduced kidney pain and slower rate of progression. So this is very important. And of course, avoid smoking. The other point, PKD doesn't just affect the kidneys. There are issues related to mood. So depression and anxiety, which may be a reaction to progression or the state of a family member. Some people, many people feel guilt having passed this disease on to their children. A referral for counseling with an appropriate provider is certainly a reasonable strategy. And I would encourage people to connect with PKD Foundation support groups, where you have folks like Judy who have experienced many of these issues, have figured out how to deal with these issues, and may be able to help you find an appropriate path forward. The other issue that your doctor should be able to talk to you about, or at least refer you to an appropriate provider, is when and if to diagnose a child. So we generally advise against diagnosing children that are asymptomatic because of risks related to insurance and making pre-existing conditions. However, if there were a treatment for a child or a clinical trial for a child, that I think changes the equation. If you're contemplating pregnancy, your doctor should discuss the risk of pregnancy in ADPKD or refer you to an appropriate high-risk obstetrician. And then reproductive decision-making is a very personal decision. And I've seen the range of decision-making from not having children to having egg or semen donors, to have genetic testing of the embryos to avoid implanting one with PKD, to not having children at all. So these are important decisions. A referral to a genetic counselor may be helpful in terms of understanding your risk of passing on the disorder, and potential testing of family members regarding potential kidney donors, especially younger kidney donors. So I'm going to speak a little bit about participation in clinical trials, and then I want Judy to weigh in. So the FDA requires that clinical trials, that is research studies in humans, be performed prior to their approving a drug for selling in the United States. So there will be no new drugs for PKD unless patients participate in clinical trials. The treating physician can inform you about trials and refer, and can certainly collaborate with the center performing the trial. And you can go to the clinical trial website. I should have it on this slide, clinicaltrials.gov, and that's a very informative site. In addition, the PKD Foundation has a list of clinical trials on its website. I'm going to turn the floor over to Judy.
I have to echo that sentiment wholeheartedly and say that in my decades of traveling this PKD road, I have participated in many clinical trials, including the tolvaptan trial. It can be a little scary, but understand that you will always be well taken care of and carefully monitored. And I have to say that personally, there's not a lot that's great about PKD. Maybe the exception is all of the great people I've met along the way through the PKD Foundation and in my community. But when I participate in clinical studies, I feel as if I'm giving back and I'm taking this, this challenge I've been dealt for my life and I'm turning it into something positive. And that's important for all of us to do. We need to find ways to do that in all aspects of our lives. But this is the one that has made me feel very empowered and productive, if you will, relative to PKD. So we're going to move on now. Dr. Perron has already really talked about what happens from the physician perspective in the later stages. I just want to reiterate some of that and remind people that there will be changes that start occurring at a more rapid pace if you are progressing towards end-stage renal disease. So again, you just need to be in that gathering of information mode. We already heard about, start to think about what are my options? What will work best for me and for my family? And I can speak personally to the comment Dr. Perron made about you're at a family gathering, you kind of know what's coming and you've never talked about your PKD before, but this is your chance to develop and perhaps refine, I'll call it your elevator speech, your couple minutes that basically gives people the what and the why. Where am I? Why am I here? And what is my need? We are never asking someone to donate a kidney. We are only telling them our story and giving them some info about what is coming down the road for us. Relative to your visits with the doctor, I want to encourage people again to be prepared for changes. And although we didn't talk about them very specifically, change is the constant in this last phase, and it affects your lifestyle because you're going to have to change the way you eat. And I say going to have to, that is only if you want to be proactive in improving the chances that your kidneys will last as long as possible. So you've perhaps heard talk of lowering your potassium, lowering your phosphorus in your diet. It's not easy. I've been there, but I will tell you that the payoff is great, and it is worth asking your doctors all the questions you need and asking for the help you may need, perhaps from a renal nutritionist or psychologist or whatever it might be, because that's what your doctor is there for. And you should expect in that last stage to see your doctor more regularly. Hopefully you have a great relationship with your doctor and you would not be troubled by that. In fact, you'd feel comforted by it, as I did. And it does not need to be a turbulent time for you. It can be a time of figuring out where you're headed, making the decisions as the time requires, and moving ahead in a smart and considered way.
And just to echo that, the last thing we want is to have an emergency start of dialysis because planning was not done. And it's the optimal treatment for most people with PKD and kidney failure is a living donor transplant that's done prior to needing to start dialysis. And that requires a lot of planning and organization, but it's much better than an emergency start to dialysis.
I would add to that the PKD Foundation is, of course, a great resource and help for all of us in these regards. In fact, this presentation is in stages going to be turned into kind of roadmap documents, checklists. And I believe the first one for early stage PKD is already complete, and you can find that on the PKD Foundation website, and the other stages will follow. So understand that you're not alone. I'm going to summarize here, just suggesting that you have a right care team for you. It may take you some time to find it. You should always be the smartest one in the room about your own situation. Know your labs, your blood pressures, where you're at on that curve. Be proactive on clinical studies. Always ask questions. Think in advance about where you're headed. Anticipate the changes. It will serve you well. And always seek out the support you need, because the power lies with you and with those around you who you empower to help you. Optimal care, best practices is within all of our reach, and I encourage you to seek them out so that you can live your healthiest life with PKD.
So your action steps following this meeting, these education sessions are being recorded, and you'll be able to review the recordings at pkdcure.org after the conference. Judy and I have both provided contact information. Just be aware, I can't give specific medical advice to people over the internet. Because that's a stupid idea, since I don't know your history and I'm not seeing you in person, and I'm not licensed in your state if you're outside of Massachusetts, but I'm happy to answer general questions. And I know Judy is also happy to answer.
I am always available. Yes, always available, and encourage you to again, check out the resources available from the PKD Foundation. There are many here for you.
So as we wrap up, before going into the Q&A session, just to let you know about the ADPKD Registry. This is a voluntary registry that's supported by the foundation, where patients sign up and provide their information in a confidential fashion to allow us to collect data on diagnosis, current disease status, and extrarenal manifestations. The first paper from the registry has been published, and there's more on the way. And this will allow researchers to better understand the PKD disease experience. And if you give permission, you'll get notified if you might qualify for a clinical trial. So you can find the registry sign up at the website shown here, pkdcure.org/registry, and please take a look. We're now going to wrap up for question and answers, and thank you very much for your attention.
Thank you for being here with us, and we hope this has been helpful. Reach out with any other questions you may have that we don't get to in the Q&A.